India is considered the diabetes capital of the world.
In our country, a person who is having a BMI of 25, 26 still has diabetes. Southeast Asians genes are something which is more prone for development of type 2 diabetes. Common symptoms which you should probably look in for is polyphagia, excess of hunger, polyuria, excess of passing urine, polydipsia, severe thirst. None of the bodies, may it be the ADA, WHO, or the IDF, don't support the utility of the term called as diabetes reversal. It is only called as remission. You cannot expect a person with type 2 diabetes for 40 years for that person to revert or remit.
The other thing that's also started becoming very popular these days are CGMs, or continuous glucose monitors.
In countries like UK, where CGMs have become a part of their insurance, people have become wise enough to use sensors to identify which food suits them. This particular drug is been approved in US even for people without diabetes as a weight loss drug.
The sequence of food having an impact on the glycemic index.
Having alcohol in moderation is acceptable and recommendable as well. Wines would be the first priority.
Hi guys, I'm Dhruv Gupta, co-founder of Orange Health Labs, and welcome to the Orange Club podcast. Here, we'll be bringing on doctors and health experts to talk about all things that help all of us live healthier and better. I have with me Dr. Raja Selvarajan, who is a senior consultant diabetologist physician at Kaveri Healthcare and Medicava Hospitals. He is an alumnus of MS Ramaya College. Doctor, welcome.
Thank you. Thank you. It's always
Super
a pleasure.
excited to have you here. The topic of diabetes management is something that's very close to my heart. A lot of family members have had diabetes, right? And I've seen them through various stages. And so, super curious to chat with you, learn more about it, and get to the heart of this, right? To start with, what exactly is diabetes?
Well, diabetes is so synonymous. Uh, People around the globe have started to know much more than even the healthcare professionals nowadays. In the sense, the incidence and prevalence of diabetes is so huge. There's a lot of awareness which is already present, but still, it's our duty to increase it to a largest strength so that we could prevent diabetes at the onset. Um it is not a complex disorder as we always think of. It's a simple metabolic disorder characterized by hyperglycemia. What does hyperglycemia means? Hyperglycemia means a level of the blood glucose above the normal metabolic levels. So when we have these levels above the normal metabolic permissible limits, this leads to a condition called hyperglycemia, and persistent hyperglycemia leads to a disorder which is known as diabetes. So diabetes could be basically classified or probably divided into three simpler formats of the condition. Primarily, the most common is the type 2 diabetes, which is the by and large the largest. You have the type 1 diabetes, you have the gestational diabetes, you have the 1.5 variant, and you have the type 3 diabetes.
Okay.
So, there are so many new variants, complex variants, but for the need of the public domain, we will keep it simple uh, to type 1, type 2, and gestational diabetes. So these all have different pathophysiologies. So if you look at type 2, it is predominantly insulin resistant status. So it's not that the person is not having insulin, the person is able to produce insulin, but this produced insulin is not something which is effectively managed or effectively absorbed by the system to metabolize the glucose in the body. So this is the typical type 2, and by and large this is the larger bulk of our patients. And type 1 diabetes is something which is autoimmune mediated. It is something close to genetics. It's also which occurs much earlier in the course of the life. Children are probably the first one to get affected, and these people, fortunately or unfortunately, have to be dependent on insulin for their lifetime. There are no other medication as of now acceptable for type 1 diabetes except being insulin. This is the second variant. And if you look at the gestational diabetes mellitus, this is a very transient hyperglycemic or a glucose metabolism defect which happens during pregnancy. So people who are not even diabetic, who don't have even a probable possible family history of diabetes, because of the subtle hormonal changes which happens during pregnancy, there's a lot of insulin resistance which develops, and this insulin resistance develops into hyperglycemia, and that leads to diabetes. So gestational diabetes probably not every person would turn up to develop type 2 diabetes on the whole long run. 95% of the people with GDM will revert, or probably they'll come back to the normal glycemic status post the delivery status. So these are the common three variants of diabetes which we come across.
Got it. Got it. Very helpful. Um, you know, India is considered the diabetes capital of the world, right? Why is this?
Well, again, it's the uh, urbanization. So the rapid urbanization and globalization across the world, which has shifted our way how we eat, how we used to work, and how we used to manage our lifestyle, has completely globalized, completely changed over the decades. If you look at 30, 40 years back, we used to probably work and then eat. Yeah, if you look at it, typically a farmer, he goes out in the morning around 6:30, finishes job, then come and eat. Then does the rest of the job. Again, he comes back after his work in the evening, then he eats. But here we eat and then try to work. So that's the first thing, meaning to say that our sedentariness, our faulty eating habits, and probably the associated social habits like smoking, drinking, alcohol, all these are something which is something which has added upon to our culture, which was not something which was very evident in the past. So the rapid globalization, and as well as extreme level of pollutions, there are certain pollutants across the environment which has known to also trigger away a possible type of type 2 diabetes and some type 1 diabetes as well, by certain viruses, certain toxins, which have also been a reason. So if you look at the various reasons why there is a transcend of the type 2 diabetes, more specific in our country being on a higher side, is because we trying to accommodate or accomplish more of a western culture as compared to our own Indian heritage.
Okay, doesn't feel like there's a solution there, because I
um,
don't think that's
no,
gonna
I
that's
think
going to reverse anytime soon.
yeah, I think it's something which we have to imbibe from our genes. We have to be more like what we were 40, 50 years
Mm.
back. We didn't probably need to have so much of sophisticated machines around you, gadgets around you to serve our day-to-day life. Even 50 years back, man and woman had a very peaceful life, isn't it? So what have we made? We have made our life more complicated with so much of gadgets and machineries around us, making us more sedentary, making us more dependent on certain others to get our simple primary job as well. Ultimately, we are making ourselves more sedentary, and this is leading us to possibly getting overweight, getting into metabolic disorders like diabetes, obesity, and heart diseases. This is a long run. So
Mm.
we'll have to break this chain somewhere. So we'll have to break down the primary curve of getting too much dependent on others for our regular day-to-day activities. We have to do our way how we were to do in the past.
But don't Indians also have a genetic predisposition to diabetes?
Yes,
Indians and South Asians.
Southeast Asians generally, our I mean our genes are something which is more prone for development of type 2 diabetes. If you look at the Caucasians and the Westerns, if you look at them, they're hugely built. If you look at if you just travel to any parts of America, you see that they are like they are like morbidly obese. You see that the waist circumference is nothing like 140, 150 centimeter, but check them, they do not having they will not be having diabetes. But in our country, a person who is having a BMI of 25, 26 still has diabetes. We are thin fat Indians. In the means, we have more of fat accumulated over the viscera. That means on the organs, internal organs have been coated or laid with fat, which is the reason we are called as thin fat Indians as compared to the Westerns who are like globally fat. It's because of the adipose tissues under the skin. Um, so the genetic preponderance along with the phenotypic expression makes us more commoner to develop type 2 diabetes.
Got it. Yeah, I've heard that before. That we in South Asians have a tendency to store visceral fat, whereas Caucasians have a tendency to store subcutaneous fat,
Yes,
which actually puts us at a higher
high
risk
risk.
of diabetes. In fact, WHO also has higher guidelines for exercise for South Asians versus the rest of the world.
Correct.
Got it. Got it. You know, I've also in the recent past been hearing a lot about pre-diabetes, right? Is this a real thing? What is this exactly?
See, pre-diabetes is a one stage before a person actually develops diabetes. These are the group of people who don't have the blood glucose levels qualifying them to be categorized into a proper diabetes. So if you look at the definition, or if you look at the diagnostic criteria for having diabetes, is a person should have an HbA1c of more than 6.5 to be ideally diagnosed to have diabetes. But 5.6 to 6.4 is a stage where we pick them up and we group them as pre-diabetes. Pre-diabetes is something where you could possibly the metabolic error is there, but it is not completely blown up into a full-blown type 2 diabetes. So if you identify these persons at this particular point, possibly we could get this persons get into severe lifestyle modifications, dietary restrictions, increased physical activity, probably getting the stress levels down, proper sleep, and all this weight management. All this could possibly help them to reverse or remit even from a pre-diabetes stage to a non-diabetic status. So any person having an HbA1c of less than 5.6 and below is considered to be in a normal glucose metabolism or a normal glucose stasis.
Got it. So above 5.6 to 6.5 is what you consider as pre-diabetes.
5.6 to 6.4
6.4. Got it. Got it. And then 6.5 upwards is
you know,
basically
diabetes.
diabetes. Is and so actually, that leads into the next thought. Like, which is the best? What's the best format? Best test, for example, to detect diabetes? What do doctors use?
See, by gold standard, HbA1c is the only test as of now available to make a diagnosis of diabetes. The gold standard test is HbA1c because it gives you last 3 months average of blood glucose levels, and when a person has an HbA1c of more than 6.5 and above, it makes a diagnosis of diabetes. But also we have other criterias, like if you have a person has an fasting sugar of more than 126 and above, and two out of three readings are on that range, possibly that will also will indicate as probably the person is diabetic, but the confirmatory test still would be a HbA1c.
Got it. So HbA1c continues to be the gold
Gold standard
standard
test.
in terms of testing, right? Now, we only know to test when we actually experience some symptoms. Are there any early symptoms of diabetes that people should watch out for?
See, many a times diabetes is asymptomatic. Many a times people go get some master health checks, they get some lab reports just because there's some preventive health check done at our office, or they walked into a mall, some camp was going, they get the blood test. Many a times it is asymptomatic. But what are the common symptoms which you should probably look in for is polyphagia, excess of hunger, polyuria, excess of passing urine. There's a lot of urination which has polydipsia, severe thirst. There'll be increased amount of water consumption, and of course there'll be delayed healing. The person may not, if a person has an wound or something, there'll be delayed healing. Unintentional weight loss. Unintentional weight loss is like many people say that, sir, I've been to gym, I've started eating well, so probably I've lost weight. If you look at the A1c, it will be 10 or 12.
Wow.
When we say that yes, you lost weight, but it is an unhealthy way in form of having developed diabetes. So the commonest symptoms would be polyuria, polyphagia, polydyspia, and possibly unintentional weight loss. These are the symptoms which we have to look in for.
Got it. Got it. Just out of curiosity, why do people lose weight when they have diabetes?
It is because the metabolism go into catabolic phase. And if you look at the metabolism, there are two phases: the anabolic phase and the catabolic phase. Anabolic phase is the positive side of the metabolism. If you have to build up weight, if you have to have any good things of the hormonal workups, everything to have a good flow, it has to be in the anabolic part of the paradigm. Catabolic phase is the negative side of the metabolism. It happens because of excessive of hyperglycemia, which again causes ketosis, and this also causes there's a lot of leakage of protein from the urine. You see, that's the reason most of the diabetes package will have microalbumin as a part of a test. It is a simple test to identify a protein leak which happens on a long term. So this protein leak results in the weight loss, and as such, whatever they consume is not ideally converted into adequate amount of the glucose. It's because of they are in the catabolic phase. It is not utilized by the cells, so they are feeling weak, lethargic, tired despite eating, and they feel they lost weight.
Wow. Okay. Okay. That's very useful. Cool. Switching gears a little bit.
Mm,
I want to talk a little bit about some of the popular trends around diabetes.
mm,
Some of the popular topics that we hear
mm,
these days on diabetes. The biggest one today, if you're on the internet in India, at least in urban cities,
mm.
at least in my experience, it's very hard to not see an ad for diabetes reversal. Okay. And I want to get your views. What is diabetes reversal? Is this a real thing? Can it be done? What's
See,
Give us a
diabetes,
lowdown on this.
yeah, diabetes reversal is a misnomer. None of the bodies, may it be the ADA or the WHO or the IDF, don't support the utility of the term called as diabetes reversal.
Just to be clear, so AD is the American Diabetes Association.
Yes, IDF is International
In
Diabetes Federation
Okay,
and WHO.
got it.
They don't use this term called as reversal. It is only called as remission. Remission is a condition where you keep the disease under control without the medication. Reversal is something which the person should not get at any point of their life. Say, for example, a person X who's probably had a newly detected type 2 diabetes 6 months back has been on rigorous lifestyle modification, maybe on some medication for some time, and over 3 months, 9 months, he's completely off medicines and he's having a very healthy lifestyle. 2 years down the lane, says something has gone wrong in his life. He's started to have a very bad lifestyle. He's started to eat unhealthy food, alcohol, possibly not working out sufficiently, stressed. Will he not get develop diabetes? He will develop diabetes. So reversal is a marketing myth.
Okay,
Remission is the medical terminology. Diabetes remission is possible. Diabetes remission is possible in a very small subset of patients. That is, patients who are young, patients who have recently developed type 2 diabetes, patients who can adhere to lifestyle modification and vigorous lifestyle changes ongoingly, and these are the subset of the patients who can possibly reverse or remit type 2 diabetes. You cannot expect a person with type 2 diabetes for 40 years for that person to revert or remit. You can manage the condition well. So this term has been not very appropriately used in medical sense, but it has made lives of many of them.
got it, got it. No, thank you for that. The other thing that's also started becoming very popular these days are CGMs, or continuous glucose monitors, right? Whether for diabetics or just generally there's a sort of a fitness trend. But originally, CGMs were used primarily by diabetes patients, right? To manage their blood sugar, to get insights into their glucose spikes. What's your view on the use of CGMs?
In fact, if I remember, the first ever CGM when I used was around 2013. 2013 or 15, yeah, 15, sorry, it's not 13, 15. Uh, so that was the first model of Abbott, which is called as Freestyle Libre Pro. Pro. Pro is the first time. So this particular sensor was completely dependent upon the doctor. So the sensor is put on the patient, but for the person to record or to retrieve the readings, he has to visit the clinic where the doctor had a reader to get the readings down and then break the readings and then come to a conclusion. This was in 2015. Now we have Libre 1, Libre 2, and Libre 3 is also probably launched in US. There's a lot of, sure, there's a lot of improvement in this particular sector. It's because it's simple, convenient, 24 bar 7, hassle free, prickless, or non invasive.
Mm,
So, this gives us a 24 bar 7 how a person's blood glucose fluctuates. Sitting at home or sitting at my clinic, I can possibly monitor a person's blood glucose level in Chicago. She doesn't have to call me, I don't have to ping him. Wherever he is, he just needs to scan his sensor 3 to 4 times a day. recommendation is 8 times per day, at least 3 to 4 times per day. All the values are then pushed into the cloud, and the cloud is accessible by the treating physician or the healthcare provider. So he's able to see 24 bar 7 the whole set of the readings, and this is every 15 minutes a recording is done and it is plotted. So the beauty of CGM is the concept of TIR. What is TIR? Is a time in range. The concept of whole CGM was built upon time in range. So this is the time the person spends in the accepted level of accepted targets fixed by the physician for that particular patient. So for patient X, I can say 70 to 180. For patient Y, I can say 100 to 200, depending upon various comorbidities, age, and other features. Once we set that target, the time spent by the person within the range what the physician sets in is called as a time in range. Time spent above the range is called as time above range, and time spent below the range is called as a time below range. So this is the concept which is evolving much beyond the HbA1c. If you were to ask, remind me of the first question which you asked, I think we are getting the answer for that. It's because TAR has overtaken HbA1c, but CGM is not affordable by everyone.
Hmm.
CGM is not something which can be done on a wide scale mode. But yes, in countries like UK, where CGMs have become a part of their insurance, so every person, at least the type 1 person, gets this sensor across the lifetime. Every 15 days, the person gets a sensor. So that's a different situation in UK and in our country. So the beauty of this particular sensor is it helps us to identify the percentage of time within the range, and we have a consensus. If a person has good control, he has to spend at least 70% of his 24 hours within the accepted modules. That is, the TIR should be minimum 70%. If the TIR is more than 70%, his HbA1c will be probably less than 6.5. 70% would equate possibly to HbA1c of 7. So we try to capture these readings at convenience, which is more meaningful, continuous, and it gives like a, in simple, HbA1c would be like a photograph, whereas TR would be like a live movie.
Yeah. Yeah.
You're recording the blood glucose across, and this will give us which part of the day or which part of the noon, or when his blood sugars are peaking, when it's troughing, and it will make us beautiful help us to make decisions in terms of medications when it has to be raised or got down. In the patient point of view, it has become a more learning tool to modify the lifestyle. Basically, apart from the patients who are having diabetes, those who are on sensors, possibly the fitness guys, it is because they would want to understand which are the foods which possibly causes a glucose spike, which is that which possibly which they should be having in moderation, which they should not be having, or which they can have it in a more spaced intervals. So people have become wise enough to use sensors to identify which food suits them, what quantity suits them, and what interval we have to place them. So this becomes and this comes at a painless prickless feature. Otherwise, if you ask a person to check even once a day blood glucose, he will not go out with a frown.
Hmm.
So now when we are getting close to 1400 readings in 14 days, that is like a wonderful data to analyze the whole 14 days glucose profile.
Oh, absolutely. I 100% agree. I mean, tried it a few times, and every time I've used it, I found it very insightful in terms of which foods spike my sugar, what should I avoid, and things like that. So it's very actionable data. And you know, the only people I've seen use CGMs, or rather, most people that I've seen around me use CGMs are primarily younger people, right, who are more focused on it from a fitness and a lifestyle perspective. But given that diabetes is typically something that starts increasing as you age, right? Uh, how do you see the acceptance? I mean, one is the price, but outside of the price barrier, how do you see the acceptance of CGMs among like slightly older patients?
When we put their indication as a must,
Hmm.
they accept it, because
Hmm.
people with brittle diabetes, we have no other option. So brittle diabetes is like the too much ups and downs. No one can have a control over it, and we cannot ask so many times the patient to check with the traditional finger prick types. So they do accept it. GDM, gestational diabetes, when people are pregnant, they're uh, I wouldn't say fussy. They're too bothered about pricking themselves, and GDM you have to do at least 6 times. So 0, 1, 2, that is pre-meal, 1 hour after your meal, 2 hours after a meal. So if you have to do 3 times a day or 9 times in 3 days, it is not going to be easy. And every time we have to make a decision based upon it, how much of insulin is required if the patient is going to be on insulin. So GDM people accept it very comfortably. So because it's a pregnancy, generally what ladies want is given, so that becomes a chance. Without any doubt, it becomes an indication. Elderly people who are very fragile, uh, who are at risk of developing hypoglycemia, and these people also accept it to make sure that they prevent one hypoglycemic episode by just wearing one, identifying the pattern, and adjusting the dosage of medication. It is acceptable, but based upon again their awareness about the CGM and the cost sensitivity.
Got it. Got it. Got it. Thank you. Switching gears to a popular drug called Ozempic. I'm sure you've heard
Yeah.
about it. We've all heard about it. Of course, it's a diabetes drug primarily. What is your take on
See,
this medication?
Ozempic is not yet launched in our country.
Hmm.
That's the first thing.
Hmm.
The molecule semaglutide is available in our country at a lower dose oral format, which is called as Rybelsus.
Okay.
Okay, but this drug is a primarily a diabetes drug, which is bound to reduce the HbA1c, but has an additional benefit of weight loss, waist circumference loss, along with reduction in blood pressures, along with getting the visceral fat down, along with possibly getting better cardiac health, cardio-renal health. So this is a simpler format or a lower dosage of semaglutide. Ribelsus itself has known to have such benefits. Ozempic, which is the higher strength of this particular drug, is been approved in the US even for people without diabetes as a weight loss drug. So Ozempic is bound to have even more weight loss, even more better HA1C control, and yes, there are a lot of what is it, gray market availability of Ozempic in our country as well, which is not currently legal. And speaking about Ozempic, I think we should keep it very superficial because it is still not approved by DCGA of our country.
Fair, fair. No, thank you. I think I completely agree with that. And it's only been a couple of years since it's been out actually.
Yes, Rivals is almost 2 years up, almost 2 years.
So it's still early days to understand what are the long-term implications of actually using some of these supplements.
I do agree. In fact, the latest trial which looked at the cardiovascular safety of this particular drug, semaglutide, which is called a SOUL study. I think it's recently came probably 3 4 days back. It was published saying that apart from all these benefits, it did show that there was a 14% reduction of MACE. MACE is the major all cause mortality in a patient with diabetes. So this is something which is a welcome boon in terms of cardiovascular safety and superiority of utilizing these drugs across the others which we have in our list.
Got it. Got it. Got it. Cool. Um, you know, I want to switch gears over to talking a little bit about some of the most common questions that we get on from diabetes patients. Right. Number one, can I eat sweets if I have diabetes?
Yes, of course. Why not? See, you need to know your moderation. You need to know your level. So it's not that a person with diabetes should become a saint. It's not at all. You need to enjoy everything, but in moderation, you should know what is that you have done. Suppose if you have had a rasgulla for the lunch, your dinner should be less of carbs. Get down more, get it more of a proteins, get it, you need to replace your overall calorie requirements. Your total calorie requirements should not exceed per day. Just eating one day will not cause your sugars to go high forever, and HbA1c will not be affected by just having a sweet a day or a sweet a week. It doesn't make a difference. I think you should enjoy having a sweet in small portion, but make sure that you burn more that day. Instead of your 10 minutes walk, possibly increase it by another 5 minutes more. That's all you require to do.
Got it. Got it. I've also been reading a lot about recent research, which fundamentally talks about the sequence of food having an impact on the glycemic index. For example, like instead of having a sweet first, if you first have fiber,
Yes,
protein, fat, and then if you have a sweet, it actually lowers the
absolutely.
glycemic impact.
Yes. So this concept is called as lente carbs. This concept of what you are describing is called as lente carbs, where you push more of fiber before. Once you push more of fiber and then you have a carb behind, the fiber content not only reduces the carb intake, but also reduces the rate at which the carb is metabolized. So it doesn't get absorbed immediately into the system. So if you look at the famous brown rice, multigrain atta, all these have something a variant of how the carbohydrate is absorbed and delivered into the system. So having more of fibers at the start, maybe with a salad, start off with a salad, some more curries, vegetable based curries, then you have your carbs. Certainly, I tell my patients 1 cup of rice, 3 cups of vegetables.
Hmm.
Either you have it front or back, doesn't make a difference. But once the carbs are, once the fiber content is more, the glycemic load gets down because the fiber will be able to delay the absorption of the carbs from the gut.
Yeah. Yeah. Any view on fruits? I mean, fruits are supposed to be healthy, but how should
Again,
diabetic patients think about this?
I think diabetes and fruit is always sometimes overhyped, in the sense you will find videos saying that this fruit is good for diabetes, this is not good for diabetes. All fruits are equivalently good because all fruits are fructose. Basically, this is another type of sugar which is present in the fruits. But some high glycemic index foods should certainly be reduced in intake. Possibly having a portion of fruit is more wise rather than having a whole of fruit. And timing of the having a fruit should be between the breakfast and the lunch. All fruits are acceptable in small amounts. Moderation and frequency has to be spaced.
What is this concept about having it at breakfast or lunch?
Breakfast is okay, but generally breakfast we don't tend to eat fruits as a part of it. In an Indian setup, how many kitchens will make fruit as a dish, or who will serve fruit as a dish? It's either, if a typical South Indian kitchen, it would be idli, dosa, or some upma or poha or whatever it is. So the reason why we supplement the fruit in between the breakfast and the lunch is it becomes like a snack which should help during 11:30 12, where the action of medicines will go up and there's a possibility of the blood glucose to dip at that particular point of time. So when you have a fruit or a salad at that, or a protein at that point of time, it helps to stabilize, and the blood glucose also doesn't go much high, and still you enjoy the having the fun of having a fruit.
Understood. Understood. Thank you. What about alcohol? Mhm.
So this is something which I came prepared for. Eh, in the sense, being in Bangalore, the pub city of our country, I think this question is very common across the dietitians or the dietitians table. Uh, Having alcohol in moderation is acceptable and recommendable as well. I wouldn't say recommendable, but at least acceptable by and large. The moderation depends. Moderation for a person X may be 30 ml, for person B maybe 60, for a person B maybe half a bottle or whole bottle. So this moderation depends upon a person's individualized assumption of what is his moderate level. So for me 30 may be sufficient, for him 100 may, I mean 90 ml may be his lowest level. So basically we have to make sure that the amount of alcohol we consume is at moderation, and when we choose the alcohol, the best part would be to think of wines. Wines
Okay.
would be the first priority. Possibly the white wine or the red wine. This should be the first priority. And if you look at the spirits, it should be all the transparent, or the more the clear the liquid is, or the more the clear the alcohol is, the lesser the glycemic index.
Okay.
So to put it simpler, vodka, tequila, it is crystal clear. So the glycemic load is very low. Beer is muddy. The glycemic load is high. So have things which are having less glycemic index, and possibly avoid the higher ones like beer, to be at the loss. But if you're a beer lover, possibly nowadays you have in local beers which is available. I don't
Mm,
know if it's available in our country, but local beers are also on the market.
got it. So how should someone even know that what quantity of alcohol is okay for
See,
them?
general recommendation is one or two. That is two pegs or 2 rounds per day for a male is what is accepted, and for a female it is one. This is the US standards, but we generally say in our standards in our country, 1 peg per day should be what we should look at. If you say 1 peg per day is also big trouble in our country because 1 peg doesn't with one peg, it ends up in one bottle. So we say 1 or 2 pegs in the weekend. So that also people find it difficult to adhere to it.
Got it. So I mean, in general, seems like the guideline is control is better when it
Yes.
comes to alcohol.
Yeah.
Got it. Got it. Uh, how do you, exercise is a very general recommendation for anyone to be healthy, even more so in diabetes, right? What do you recommend for people in terms of, for your patients? What
See,
kind of exercise? How much?
exercise is one of the most important pillar stone in the management of type 2 diabetes. To be very specific, if a person exercises well, he can even cheat his diet. The whole concept or the whole mantra of having diabetes under control is burn more than what you eat. If your burning calories is higher than what you consume, your dynamics will be within the acceptable range. So exercise not only helps in getting the blood glucose down, it helps in getting your blood pressures down, it helps in optimizing your weight, it helps in possibly improving the bone and the muscle strength of your person, relieves anxiety, stress, and more than that, it gives you a self confidence that I'm able to run X kilometers. So overall, exercise has to be a part of the management of type 2 diabetes. But when we do tell the patients to do it on a regular basis, you see that most of them, sir, now that I have developed diabetes, I'm going to follow a very strict diet. I've joined Gym X. I've taken a membership. I'm going to join. I have 10,000 rupees is what I press. From tomorrow, I'm going there. Yes. After 15 days, when he comes, sir, last 15 days, 2 days I couldn't go because it was rainy. And third day, my cousin came. So it becomes, there is always an interruption in the activity. What I say my patients is at least 120 minutes of a brisk, moderate intensity workout on a week is something which is recommended. You do however it is. See, it could be a combination of aerobic, anaerobic, or it could be even some what is it? A mixture of playing a sport, playing a Zumba, playing some playing the sport Zumba or some even some sort of a run marathon, anything good could be. uh, Aerobic exercise predominantly is like cycling, swimming, or even running and playing any sport. This helps uh, in a larger way as compared to resistance training, because while doing an aerobic exercise, the muscle takes up more of glucose.
Got it.
Muscle takes up more of glucose, and therefore there is a lot of glucose expenditure which is happening, which will help the blood glucose to come down. But if you take in terms of a resistant training, so say, may it be again the weightlifting or band resisting, all this weight resisting exercises, there is again a burn down of glucose, but not to the extent of an aerobic. And once the aerobic exercise pushes out more of glucose levels, the insulin sensitivity increases. So the muscle starts to take more of glucose because the insulin sensitivity is high. So the insulin resistance comes down. So sugars tends to come down. So having a possible combination of both aerobic and anaerobic, or weightlifting and possibly resistant training should be the choice of exercises.
Got it. Got it. And you're saying about 2 hours a week, 120 minutes.
120, even the guidelines is only 120.
Okay.
If you look at the ADA recommended guidelines, 120 minutes of moderate intensity workout is all we need.
Understood. Understood. What about sleep? How does sleep associate with like your blood sugar levels?
Sleep is a very important factor, not only for diabetes. I think it is a reset button of our brain. Fortunately, we have a reset button in our CPU to switch it off and get it rebooted, but we don't have one. The one possible which we have is the sleep. So we shouldn't compromise on sleep at any point of time. Idealistically, at least 6 to 8 hours of sleep is something which we should aim to get, which has to be uninterrupted. In the sense, there should not be disturbance in form of getting up, may it be because of urination, may it be because of loss of sleep during the cycle, whatever it may be. We should have uninterrupted sleep. The reason why we stress upon the sleep is uh, this uninterrupted sleep uh, it has an impact on the neuroendocrine hormonal axis. So most of the hormones get secreted in a pulsatile manner at the peak in early morning between 4 to 5. 3:30 to 4:30. This is the time where there is a huge hormonal surge. For the hormonal surge to have at its best, you should have a good amount of uninterrupted sleep. People working at night shifts. Look at our Bangaloreans. There's a great incidence of type 2 diabetes occurring in young adults. It's because they're working all the night. Their sleep is interrupted, the hormonal axis interrupted, distorted. They start to develop insulin resistance, and that's the reason they get diabetes at much younger age. So sleep is a very important factor, and having the sleep rhythm addressed should be a priority and should be one of the main tasks assist with management of type 2 diabetes.
Super, super. Thank you. This has been very insightful. I think just to wrap things up, we wanted to get a sense of as we look forward, right? Uh, as a doctor, what are you most excited about? What are the areas of new development or research or new treatments that are coming out that you feel would be game changers, or that patients should know about?
See, I think at the patient point of view, what the patient would be looking for is a non invasive glucometer. Not everyone would be able to afford a CGM, but once a non-invasive glucometer comes down, I think that will be able to reach a larger scale, and that will be a need of every house, at least in our country. Every house at least has one or two diabetes in our patients.
Hmm.
So that is the sad state of our country. So having a non-invasive glucometer or a less invasive uh, glucose monitoring system should be what the patient should be looking for as a monitoring device. But more than that, he should be looking at how healthier he can be by adapting a better lifestyle, having a good work culture or a safe work environment which is stress free, avoiding night shifts, and possibly having a healthy eating, making himself physically active. These are the things at the patient point of view he should look at preventing the disease. Once the diseases come in, monitoring becomes the second, then comes to the medication point of view. Medication wise, we have a whole length of good already available medicines, but there are wonderful molecules in the pipeline. We talked about the Ozempic or the semaglutide. We have another dual incretin, which is called as a trazapatide, which is possibly about to launch very shortly in our country. So this is super drug. It is going to cause even more weight loss, even more better diabetes control, even more better metabolic control. This one thing which we are looking for. It's probably named as Monjaro. It's expected anytime. And also, apart from trizapatide, we have once a week insulin, which is also going to get probably launched early next year. It's called as icodec, where the person will be having to take only one injection weekly once, and that would be able to cover the basal requirement of the insulin for one whole week.
Wow,
Mm.
that is that's big.
These are possible certain new things, and there are multiple. You have the oral insulin in the pipelines. You have nanopellets being injected into the subcutaneous tissue to produce insulin. These all are in the trial phases and the research phases. But two or three, which is expected for sure to come, is weekly once insulin, trazapatide, and possibly, yeah, we have now for the type 1 we have telinuzab. That is what you can it's a type of a immunotherapy which is used to possibly prevent or delay the onset of type 1. So a person is probably going to develop type 1 diabetes, then administering this particular immunotherapeutic agent would possibly delay the onset or possibly even prevent the onset of type 1.
Wow, wow. Considering that we're the capital of global capital of diabetes, I think these should
Kept in
be
mind,
very
surely.
impactful
Yeah.
for us. Super. Thank you, doctor. It's
Thank
been
you.
great chatting with you.
Excellent. Same here. Thank you. Pleasure.
Hope you guys enjoyed the podcast. If you like it, comment, subscribe, tell your friends about it, And if there are any topics that you want us to cover, just add it in the comments and we'll make sure we'll cover them in the future.